Ready to start? Yeah.
Hi there. Yes, I am.
I'll introduce our speaker for today, Roger Deere, MS, and he is the UWCTRI,
That's right.
Senior Outreach Specialist for the Eastern and South Central regions of Wisconsin. Roger graduated from the Minnesota State Mankato with a bachelor's degree in English and earned his master's degree in applied leadership for teaching and learning at the University of Wisconsin-Green Bay. The mission of UW Center for Tobacco and Research and Intervention is to expand our understanding of tobacco dependence and its treatment, and to use this knowledge to design and implement interventions that will significantly reduce tobacco use in Wisconsin and the nation and beyond. Based in Oshkosh, Roger is available to Wisconsin healthcare organizations with improving their standard of care for treating patients who smoke or chew tobacco.
Thank you very much for the introduction. And thank you for being here this afternoon. I have nothing to disclose. I am a former tobacco user. This is a picture of me in 1971, 72, 17 years old in a Shopko photo booth up in Green Bay, Wisconsin. The height of my maturity and intelligence. After I quit smoking cool cigarettes, I chewed Copenhagen for a couple of years. So I've got some experience in this stuff. I learned how to smoke cigarettes from this guy. This is my father. This picture was taken about 1952 in Fort Francis, Ontario, about the time he started smoking. A lot of people smoked after the war. My dad was a hockey player, like a lot of, at the time, young men in Canada. He tried out for a new semi-professional hockey team that was starting in Green Bay in winter of 58-59, called the Green Bay Bobcats. He made that hockey team, continued to smoke all through his hockey career. Back then, they didn't have any plexiglass. As you can see, they used a wire for above the boards. And as my dad here having a discussion with an opponent. My dad smoked all the time and everywhere. So he began smoking about age 16 in 1951. He was at first advised to quit smoking in 1991 when he was 56 years old. He had some cartilage floating around, probably from his hockey days, and he had knee surgery in 51. At the time, he went in for a pre-surgery examination, and somebody, a doctor or a nurse, told him that he needed to quit smoking. It was the first time he was ever advised to quit smoking. So he did. He said he would think about it. A couple weeks later, he got a prescription for patches, and he was able to quit smoking. He was very proud of that. He used to take my mother out on the anniversary of this quit date every year, and so it all went well. So in October, throughout the summer of 1995, he started to lose weight. His face was puffy in the morning. Later turned out he had vena cava syndrome. So on October 9th, 1995, they asked him to come in and take an x-ray. And the x-ray showed a shadow. On October 15th, they took this picture, this MRI. You can see the mass. And on February 12, 1996, he was dead of cancer at the age of 60. What's the point of the story? The point of the story is that if somebody had spoken to Dick Dyer not in 1991, but in 1981 or in 71 about the need for him to quit smoking, he might still be here. So if your patient smokes or chews or uses electronic cigarettes, ask them to quit smoking. Help them quit, because they will listen to you. So these are all the good reasons why you should help your patients quit smoking. If your patient smokes throughout his or her lifetime, they'll probably end up losing an average of 14 years of life. Most of the people who are smoking see people like you every year, and half of them have tried to make a quit attempt in the last year. So there's fertile ground out there. And it takes people an average of 6 or 7 attempts before they finally quit for good. Overall, about 500,000 Americans check out every year because of tobacco-related disease. One of the things that we've been able to do in public health is totally eradicate polio. I know there are still small pockets of polio that crop up in this country because of people who don't believe in vaccinating their children. But starting in 1954, all throughout the following generation, there were scenes like this in grade school all the time. I can remember shot day at Chapel Elementary up in Green Bay. It happened twice a year. It wasn't a day that anybody looked forward to. But we stood in lines and people like you stuck needles in their arms. And scenes like this were common. And you can see right here that the doctor's got a gagger hanging out of his mouth. I don't think you see that anymore. So the times have changed. The tobacco use and treat tobacco use and dependence guideline has been 3 editions. The most recent one was updated in 2006. I have a few copies up here if you would like to take one. So we're all born with nicotine receptors. If we never smoke, those receptors will never multiply. They will be dormant, and obviously they will die when we die. But when we start smoking, the nicotine molecules find these A4B2 subatomic receptors in our brain. They go right into the center of those receptors, and the brain begins its happy dance. This will tell you what happens to us when we smoke.
Cigarette smoke contains more than 4,000 different chemicals, with nicotine being the primary component. Nicotine is a naturally occurring colorless liquid that comes from the tobacco plant. It is considered an addictive drug, making cigarette smoking the most prevalent form of nicotine addiction in the United States. Cigarette smoking is a cause of many preventable diseases worldwide. The effect nicotine has on the brain and the body is complex. With each cigarette, a smoker takes in approximately 1 to 2 milligrams of nicotine. The smoker immediately experiences a high after exposure to nicotine due to the drug's stimulation of the adrenal glands and resulting secretion of epinephrine, also known as adrenaline. The rush of adrenaline stimulates the body and causes an increase in blood pressure, respiration, and heart rate. Nicotine also causes the release of dopamine in the brain. Dopamine is a chemical responsible for sensations of pleasure. The release of dopamine causes the smoker to experience a sense of euphoria following nicotine exposure, similar to other psychoactive drugs. The feelings of a high and of euphoria enhance nicotine's addictive effect. Repeated exposure to nicotine results in the development of tolerance, the condition in which higher doses of a drug are required to produce the same stimulating effects. When an adequate level of nicotine is not maintained, the smoker will experience symptoms of nicotine withdrawal. These symptoms include decreased heart rate, difficulty concentrating, nervousness, headaches, increased appetite and weight gain, insomnia, irritability, and depression. While these symptoms will diminish over time, the adverse effects of nicotine withdrawal make it difficult for most people to quit smoking. However, there are many resources and techniques available to assist individuals who want to quit. Consult with your healthcare professional for information on these resources.
So when they did the research and put this latest edition of the guideline together, there were 3 barriers that clinicians reported as to why they did not want to treat tobacco use. They didn't think there was enough time. They said, my patients don't want to hear about it, and they felt powerless to help patients stop. Well, the evidence shows that minimal interventions of 3 minutes or less is going to compel a lot of people to try to quit smoking. So bring it up. As for the objection that they don't want to make their patients angry or their patients don't want to hear about it, they discovered a study that reported people who had, smokers who had been talked about their tobacco use or advised to quit had a higher rate of satisfaction with their healthcare provider than those who weren't even asked the question. So the evidence supports you talking to your patients about their tobacco use. And there are effective clinical interventions that exist. We'll talk about a few of them here. There's a mnemonic that the researchers who put this guideline together developed. It's called the 5 A's. You all have a little 5A pocket guide. You can take it with you on your rounds. If you use this method a few times, you won't need this very long. You'll know it by heart. The first A is to ask the question. This is probably looks like something that you might have used 10 years ago. This is probably a better illustration of how that question is asked. But somebody needs to ask the question, do you smoke? Then once you find out that they smoke, you need to advise them to quit. And you know, obviously you don't want to be scolding them, but you want to tell them in a clear, strong, personalized manner. Mary, I know you told me you like smoking, but you've got heart disease in your family, and one of the most important things you can do to improve your health is to stop smoking, and we can help you. So make it personalized, make it clear, and make it strong. So after you advise them to quit, which is the second A, you need to assess where they are in their thinking about quitting. You can ask them an up or down, yes or no question. Are you willing to try to quit at this time? I can help you. Or you can ask something more open-ended, which will probably generate a conversation. What are your thoughts about quitting? And once your patient starts sharing his or her thoughts about why they don't want to quit or why they do, then you're on your way. So then you should have them develop a quit plan, and this is probably one of the most important slides that is in front of you today. You want to help your patient set a quit date, ideally no longer than a month out, ideally within a couple weeks. That will give your patient time to prepare emotionally. They can tell their family and friends they're going to try to make a quit attempt. If you decide that, you and the patient decide that medications will help them quit, it'll give the medication a chance to get into their system. You should talk to them about their past quit attempts, if any, and what they foresee as challenges to having a successful quit attempt. You want to have your patient avoid using alcohol. In the first month or so after their quit attempt, people who relapse have alcohol in their system half the time. And you want to warn them to be careful around other smokers as they begin their quit attempt. And the fifth A is arrange for follow-up. If you have the wherewithal to have somebody from your office call your patient a week into their quit attempt to see how they're doing, that is a great sign of support, and it will reinforce what they're trying to do. So, medication and counseling improve treatment outcomes by 70%. So, your counseling plus medications gives them the best chance to quit. There are 7 first-line pharmacotherapies. There they all are. Bupropion is the one of 2 non-nicotine medications approved by the FDA. It's available by prescription only, and it presumably blocks the neural reuptake of dopamine. Now, bupropion comes in 2 forms. It comes as Wellbutrin for depression and Zyban for treating tobacco dependence. It's the same drug. These are the contraindications. Some of the side effects are insomnia and dry mouth. And the dosing is right there. It's also on a sheet in front of you. Who writes bupropion here? And how's it working for you?
Great.
Good?
If people are really intent on quitting, it worked great.
Good. How about you? Don't you like being asked a question when your mouth is full? I'm sorry. It works good? 50-50? These are the 5 NRTs, nicotine replacement therapy. Nicotine is the active ingredient. So the medical contraindications, recent MI within the previous 2 weeks, if they have arrhythmia, an angina, or if it increases their high blood pressure. Nicotine gum comes in 2 and 4 milligram dosages. You should tell your patient to chew it a couple times until they experience a peppery taste. And once they experience that peppery taste, they should park it between their cheek and gum. The nicotine is absorbed through the buccal mucosa. When that peppery taste disappears in 5 or 10 minutes, have them give them a couple more chews and move it to the other side. They should use it as many pieces as they need during the day. To make it really effective, if your patient is able to wash his or her mouth out with water to neutralize the acid content of their mouth, it seems to work better. Nicotine patch is available both by prescription and over the counter. Usually goes between the belt and the neck. If there's some skin irritation, you should rotate the patch around the body. If they report insomnia or dreaming, you can tell your patient it's okay to take the patch off at night. That seems to help with that. Typical dosing is in front of you, 4 weeks of 21 milligrams, 2 weeks of 14, followed by 2 weeks of 7 milligrams, just to taper them off. All the while they're not smoking. Nicotine lozenge is just like the nicotine gum. Get the oral area neutral from acid-based perspective. It's used just like a cough medicine, just like a cough drop or a lozenge, which it is. The nicotine nasal spray is by RX only. It best replicates the immediate nicotine pop that a cigarette smoker experiences. Of all 7 agents used by themselves, this is the most effective lone agent. And you really don't squirt a whole bunch up your nose. You just kind of put a drop in the oral cavity. It's really it's a strong thing. A lot of patients who use this, they report a nasal drip, and their eyes might water the first few days, but if they give it a week, those symptoms will disappear. The nicotine inhaler is available by prescription. Who has prescribed this? And how's that work for your patient?
They like it. They seem to feel it replicates some of the action with their hand.
Yes, that's what I've heard. And a couple of my friends have quit smoking using the nicotine inhaler. You kind of sip on the end of the inhaler, and you should avoid either drinking before or after. And varenicline was approved in 2006. We all know it as Chantix. And it's another non-nicotine medication. 2 most common side effects are nausea and wild dreaming. And the thing about Chantix, go back here, Chantix is the first designer drug to treat nicotine addiction. And earlier I showed you this slide where we had all these nicotine receptors, and then we have the nicotine in it. How Chantix works, you start taking it a week before your quit date, and the Chantix molecules occupy the center of these nicotine receptor cells. So as your patient moves toward his or her quit date, the nicotine that they're ingesting via their cigarettes will have fewer and fewer places, cells to occupy, and so they don't get the big pleasure pop that they got before, because the varenicline molecules are occupying all the nicotine receptor cells. So as a consequence, by the time their quit date rolls around, their urge to quit is reduced, mainly in part because smoking is no longer as pleasurable as it was before. I like to tell patients that varenicline works like a good football team. Like when the Packers are playing well, they block and they tackle. Varenicline blocks the rewarding effects of smoking at the same time it tackles withdrawal symptoms. Blocks the rewarding effects, tackles withdrawal symptoms. Combining medications, at least 2 medications have been approved by the FDA. The patch and bupropion. Together, those 2 together have highest efficacy of helping people quit smoking. We recommend the patch with the gum, the lozenge, or the inhaler. Something that is some new thinking in treating tobacco use is to, if people want to use the patch, you can start them on the patch right away before their quit date. And the research has shown that starting patients on the patch right away increases the odds of quitting about 25%. And it seems to weaken the link between smoking and pleasure. What I think is happening, if somebody's on a 21 milligram patch and they're also smoking cigarettes with that patch on, they're experiencing probably a mild form of nicotine poisoning. People who have been smoking for years know they've been self-medicating for a long time. They know exactly how much nicotine they want. If you put the patch on and they start smoking on top of it, I don't think it feels very good. There are 4 populations that the guideline recommends not be given medication, mainly because there's not enough research to show that these 4 populations are positively affected by it. A light smoker, according to the guideline, this is a person who smokes 9 cigarettes or less per day. If your patient is a pack-a-day smoker, they are spending about $2,500 a year here in the great state of Wisconsin. So if they're thinking about quitting smoking, a question you could pose to them is to say, do you think you'd have better uses for $2,500 a year than supporting the tobacco companies? Motivational interviewing is, there are 4 tenets of motivational interviewing. EDRS, express empathy, respect, and understanding. It's always a good idea to ask your patient, hey, would you mind if I talk to you about your tobacco use? Help your patient develop a discrepancy, help them understand where they are now and where they want to be. It is not going to be the same with the cigarettes in their life. If they give you some resistance, you just want to roll with it. You certainly don't want to argue. You can kind of rephrase their objection to it and tell them, I understand. It sounds like you don't want, you're really stressed out and you don't think that you can quit smoking at this time. Just rephrase it, just roll with it, keep the conversation going. And always be a cheerleader, always support the idea that they can quit smoking. Millions of people have quit smoking. There's a decision-making worksheet that's in front of you that is, helps your patient narrow his or her thinking about why they like to smoke and why they should think about quitting. And you can either interview your patient and write down his or her answers, or you can send this home with the patient, and it'll help them see the light. This is some sample answers here. There's another good tool that's in front of you. It's called the assessment scales. It asks the patient to find out how ready they are, how important it is to them to continue smoking or quit smoking, and how confident they are that they can smoke. So for this important, like this middle question, on a scale of 1 to 10, how important would you say it is you quit smoking? And if they say, well, it's 3, it's somewhat important. If your follow-up question is, when you say it's a 3, how come it's not a 1 or a 2? So they'll start talking about some of their concerns about their smoking. That's the idea. Get them to verbalize the things that they've been thinking all these years about why they should stop smoking. You can talk, the beauty of this is you can talk on either side of this number. If they say they're at a 5 in their confidence that they can't quit smoking, ask them, what can I do to move your confidence from a 5 to a 7? What can you do to move your confidence up? What has to happen? The 5 R's are kind of the cliff notes of motivational interviewing. And this is another mnemonic developed by the guideline. So the first thing you want to do is tailor the advice and discussion to each patient. So if your patient has recently been diagnosed with diabetes, say, Jerry, I know we know that you've been diagnosed with diabetes, and your smoking is not going to help me treat you for that condition. It's going to be with you for the rest of your life. So quitting smoking would improve your life. Then you would ask Jerry, if you continue to smoke, Jerry, what would be some of the risks to your health? And hopefully Jerry will tell you that, well, make my diabetes worse. I get cancer, heart disease. And then after he outlines the risks, ask him to outline the rewards if you quit smoking. If you stop smoking, what good things would happen? And hopefully he'll tell you 1 or 2 things. So after he tells you the risks and rewards, ask him what's stopping him from trying to quit smoking. Have Jerry tell you what the roadblocks are. And he will, hopefully. And then the final R is repetition. So, thank him for having this discussion on his smoking. Tell him that we have a lot of things to think about here. And the next time you see him, you'd like permission to talk to him about his smoking again. Because it's important that he quit smoking, and you wouldn't be doing your jobs if you just let it slide. So relevance, risk, reward, roadblocks, and repetition. Show of hands, please. How many clinicians in the room have had their patients who smoke talk to them about e-cigarettes? It's the newest thing. They come in three different forms. The so-called mini or the cigalites, the mid-size, and these are the ones that are the most becoming the most popular. They're called mods. A lot of them are shaped like a pack of cigarettes, not surprisingly. And the reason why they're so big is they've got bigger batteries, and the user can modify the amount of liquid juice, the nicotine content that they're getting. So my boss, Dr. Michael Fiore, developed a protocol for treating patients, talking to patients about their e-cigarette use. I think it was in the New England Journal of Medicine a few months ago. The most important slide here is this one. When discussing cigarette substitutes, many patients may propose that they use e-cigarettes. You should inform your patient that the health of e-cigarettes are not known, research is just starting, but that they are likely less harmful to them than combustible tobacco products. And if your patient wants to try e-cigarettes in lieu of combustible tobacco products like cigarettes, it's okay to encourage that. We should emphasize that the ultimate goal is to complete cessation of both tobacco and vaping, e-cigarette use. And using both together is not a good long-term goal. Not a good long-term goal. Now, on April 28th of this year, the New England Journal of, the Royal College of Physicians published a study that they did in Britain on e-cigarettes. And some of the results were surprising. The study concluded that, that e-cigarette use did not lead to use of regular cigarettes. They found that e-cigarettes was an effective remedy to help their patient get off combustible tobacco products. And their study also seemed to say that younger people were not starting into tobacco by going to starting with vaping e-cigarettes. Well, we didn't really feel too good about that over here. I know the director of the campaign for tobacco-free kids published a rebuttal, but still the Royal College of Physicians, you can look this up, is a pretty reputable outfit, and that's what their study showed. There are a few things that we're concerned about with these cigarettes. Most of them are manufactured in China, and God only knows what goes on over there when they make things. So there's no manufacturing standards. Nicotine poisonings have started to accelerate since 2010 when e-cigarettes first came on the scene. In 2014, they peaked at the National Poison Control Center reported just slightly less than 4,000 calls to it about kids being poisoned by nicotine. You know, the parents leave their e-cigarette toys out, and the kids get up in the morning, especially little kids who are curious, and they screw around with the vials of the seed juice, they spill it on them, and the consequences are often tragic. And you know, we're concerned also in this country about the renormalization of the smoking type behavior in our society. So one of the things that you have going for you here in this state is the Wisconsin Tobacco Quit Line. How many people in the room have demonstrated the quit line or had their patients call the quit line? All right, good. It's great. It's a great resource for you. It's free. It's phone-based, obviously. All the counseling is tailored to the individual. It's private. 24 hours a day, 7 days a week. We have a Spanish-specific quit line. They'll get once they call the quit line, they'll get slotted into a conversation with a quit coach. That quit coach will help them set up a quit plan. If the patient does agree to set up a quit plan, their personalized quit plan, they will receive 2 weeks worth of patches, gum, and lozenges. Those will come by post. And it's a good starter kit. They'll also receive a great guide on quitting smoking, and they'll be given a password specific to them so they can go to the Quit Line's online, their online program. They can talk to web coaches all the time. So there's some Quit Line brochures here. I think Sue's got a whole bunch of them. If you need more, you can contact this person, my colleague, Kate Kubinski. One of the things that you should talk to your patients about when they're smoking, especially young people, is what the ravages that that tobacco smoke does on the epidermis. It just ages people prematurely. I'm going to show you 3 or 4 sets of twins. One of the twins smoked throughout his or her life. The other twin did not. You can see the differences here on the twins that smoked and not smoked. This one obviously is the non-smoker. I always have problems with this one. I think the guy on the left probably did smoke. That's what's pretty clear here. So if you have some young people in front of you and they have beautiful, tight, pink skin, tell them that, the best way to protect your protect your skin is to stop smoking, because it does turn middle-aged people into looking like they're old-aged people in 10 or 20 years. So everybody has a trigger for quitting. I mean, if your patient, I've heard stories where patients won't quit smoking necessarily so much for themselves, but they'll quit smoking because of what their smoke does for their dog, or their cat, or their parakeet. Everybody has a trigger. In 2002, I was full of political ambition, and I decided to run for the state assembly up in Green Bay, Wisconsin. Something I always wanted to do, give it a shot. So my campaign got its hands on what they call a walk list. And a walk list will tell you who lives on a specific address, and you go out throughout the neighborhood, you knock on their door and say, hello, Mr. and Mrs. Mertz, I'm Roger Dyer, I'm running for the state assembly. I just want to introduce myself, and I want to know if you have anything that's bothering you, blah, blah, blah. So anyway, I was about 2 months into it, and I came to an area of Green Bay, a bunch of apartment buildings, and I saw somebody on my walk list. Her first name was Lynn, I won't tell you her last name, but it was somebody that I had lost track of. I went to grade school and junior high school with her, and I remember seeing her my first year of sophomore year of high school, and then she just disappeared. So I knocked on her door, and lo and behold, it was my long-lost classmate. And she invited me in, and her apartment was smaller and was filled with smoke. She was obviously a smoker. So we sat down, we talked for a few minutes, and she shared with me that she was diagnosed with schizophrenia when she was a sophomore in high school, and she dropped out of high school and never graduated. But she had this collection. She had 2 shelves, and there was porcelain dolls. She collected porcelain dolls. That was her thing that she was most proud of. So she showed me a bunch of them, and then I wet my finger and put it on the cheek of one of these porcelain dolls, and underneath it was some beautiful white skin. There was a lot of brown soot from her smoking on the porcelain doll. I said, look, Lynn, look what your smoking is doing to your dolls. And I really wasn't trying to get her to quit smoking, but it was just, an aside that, she might want to clean her dolls up. So about 3 months later, 3 months goes by, election day comes, Roger Dyer loses by this much, and I get this call at work. And here it is, it's this Lynn person. And she tells me 2 things. First thing, she tells me that she voted for me. She's never voted in her life. I was very pleased with that. I thanked her for it. Made me feel really good. And she says, second thing she told me, she said, I quit smoking. I said, I was really happy because I was in this job. And I said, why did you quit? She said, well, I didn't want to hurt my dolls anymore. She had quit smoking because her cigarette smoke was making her dolls dirty. That was her trigger. So everybody has a trigger. Everybody knows this story. Tortoise and the Hare, told 2,600 years ago. And the slide is up there to illustrate the power of storytelling. Before we had all the social media we have today, before radio, before the printing press, even before written language, the way we shared information was through storytelling. I mean, our brains are hardwired to remember stories. Now, I told you the story of my dad to start this thing off, and if you have stories of somebody who quit smoking, it doesn't need to be a long, in-depth thing. Just tell your patients a story of who was struggling to quit smoking, a story in which one of your other patients was able to quit smoking. They will remember that. They will take heart, and it may help them quit smoking. So become storytellers. Does anybody have any questions? Yes, sir.
Great talk, thanks very much. So my question is in regards to the cheapest products that you can offer patients I'm a cancer physician, and we see a lot of patients, and the knowledge doesn't necessarily change behavior is what I'm finding out. But they're struggling, some of them are struggling to quit because they can't afford the lodgers, they can't afford this or that. And I tell them, well, you know, change the cigarettes into, they're always going to do that. What is the least expensive product out there that they can buy over the counter or prescription or whatever it may be, that would help them smoking?
I think you can get a pack, you can get a box of nicotine gum for about $40, $40 to $45. That's the cheapest I know of. I don't know what patches cost. Does anybody else know what patches cost? I think they're gonna have $40 to $45 is what I've heard that box of nicotine gum goes for. I can't imagine that the other NRTs that are available over the counter to be that much more expensive.
Yeah.
But the,
I was just saying, you know, I've had a lot of patients, and we actually have a fund that we sometimes utilize to help patients quit, basically by providing money for them so that they can buy some of these things. And, you know, the prohibitive factor is that patients don't have money. They really.
all right. So listen, if you shoot me an email today or tomorrow, I will send you a link that a lot of these drug companies, if your patient has genuine hardship, they can get these medications for free. But we have a link on our website, and I'll be happy to send you that link if you want to just shoot me an email. Yes?
Have you ever used chewable tobacco or these like Swiss smokeless tobacco for quitting?
Is quitting, you're asking me if chewing tobacco can help people quit smoking?
Yeah.
There's no scientific evidence that it does, but it worked for me. I went from smoking cigarettes to chewing tobacco. But the research shows that chewing tobacco is even more difficult than to quit than cigarettes. The reason why is twofold. When somebody puts a little pinch of like Copenhagen in their cheek and gum, that pinch is probably there for 15 or 20 minutes. The nicotine content in Copenhagen, a little tin of Copenhagen, there's 4 times as much nicotine in that tin of Copenhagen as is found in 4 packs of cigarettes. 1.8 milligrams of nicotine in a typical cigarette. And there's 144 milligrams of nicotine in a can of Copenhagen. You divide 1.8 into 144, you'll come up with 80 cigarettes. So they're exposed to nicotine longer, and the nicotine content is stronger. The only I've got a friend at Mayo Clinic who's devoted to helping chewers quit, and his research shows that varenicline is probably the most effective long-term agent for helping them quit. He's done some research that show that he really patches them up. He gives them 2 21 milligram patches at a time. They're able to quit on the short term, but once those patches come off, they go back to chewing again.
But chewing is not as harmful as smoking.
It's not a what?
Chewing tobacco is not as harmful.
That's correct. That's correct. There are 78 carcinogens in cigarette smoke. There are 28 carcinogens in chewing tobacco. Is it safer? Yes, but I always tell people who ask me, it is safer in the same way that jumping out of a 3rd-story window is probably safer than jumping out of a 6th-story window. You're still playing with fire. So, any other questions? Well, thank you very much. It's been a great group. Appreciate it.